Шановні колеги, ми маємо рухатися далі. І зараз ми продовжимо наше засідання, продовжуємо наше обговорення. І я з великим задоволенням хочу надати слово професору Хешамі Хамода з Гарварда, це Бостонська психіатрична школа, і ми матимемо можливість далі говорити про проблеми ADHD. Прошу, Хешам.
So good morning. First of all, it's really a great honor to be here with all the wonderful colleagues. So thank you so much for the invitation. So I will try to speak very slowly, not because it's 4 a.m. in Boston and I'm half asleep, but just to allow for translation. So apologies if I sound like a robot or something. Okay, so I don't have any conflicts of interest to disclose. I've received funding, not pharmaceutical though, from the National Institute of Mental Health for an ADHD imaging study. So what I was hoping to do today is to start off with a background about ADHD. Then talk about kind of the development of ADHD over the lifespan. And then the medical management of ADHD, which is the biggest part of this talk. Other management approaches and then new developments. Okay, I really like to start usually with this slide. Does ADHD exist? I know certainly, you know, for this type of audience, this may not be as much of a problem, but this is a problem we got asked even in the United States by patients, by families, by teachers, and sometimes even some colleagues still doubt that ADHD is a true diagnosis. So there's evidence from different fields. There's evidence from genetics, there's evidence from neuroimaging, that's actually my area of research, and certainly epidemiological evidence. So in terms of genetics, twin and adoption studies suggest about 75% heritability rate. Now with the ability to do genome-wide linkage studies, they've identified chromosomal regions that are shared more often than expected by chance among ADHD family members. There is certainly a lot of evidence coming out from imaging studies. There's structural difference, there's functional differences. So some areas are smaller, such as the dorsolateral prefrontal cortex, the caudate, the pallidum, the corpus callosum. And evidence from functional studies of increased DAT, which is the dopamine transporter binding in the striatum of patients with ADHD. There's also evidence from EEGs of elevated levels of slow wave activity in folks who have ADHD. And there's a lot of evidence from epidemiological studies, although the number itself might vary depending on the country and the study. But in the US, we say it's about 8.4%. In other countries, it ranges from 1 to 20, but it exists everywhere. And then the last one, I call it the headache test, and it's certainly not, I think, scientific, but it's an anecdote. When I was completing my training at Boston Children's Hospital about 10 years ago, there was a subset of patients who would always come to my office, and they would leave, and I would have a headache. And then, I would sit down and think about it and realize these are the kids who are, come and, start touching you, start opening your drawers, do a flip-flop in the room, and every time I would leave with a headache. So when people doubt, the studies and everything, I usually say, if you don't think this exists, come spend one day with me and you'll be a true believer. So in terms of the definitions over time, how we call this entity hyperkinetic disorder, ADHD, it's changed. From the first descriptions by Still in about 1902, where he described this sense of moral discontrol. This is kind of how it started. Hyperkinesis, these kids have a moral problem. And then with the wave of encephalitis that hit in the 1920s and 1930s, people who were affected by encephalitis were noted to have, ADHD-like symptoms. And this is where this description came: minimal brain dysfunction. And it was by coincidence that in 1937 in Bradley Hospital in the United States that they realized that amphetamines actually help children who have this hyperkinesis. And then the name changed a little bit between the different DSMs. So hyperkinetic disorder of childhood, ADD or EDD plus H, and then ADHD, and until now it's ADHD, but you never know what's coming up. So a little bit of what is a myth and what is a fact about ADHD. So we used to think of ADHD as a childhood disorder. Now we understand that it doesn't just go away the day you turn 18, it's also an adult lifespan disorder. It only applies to boys, that's not true. It also applies to girls, although many of the girls have inattentive problems are not necessarily referred for treatment. It's not a Western phenomenon, it has a worldwide prevalence. It's not a behavioral disorder per se, it has behavioral components, but it is a true genuine medical disorder. It reflects inadequate school funding. That's not 100% false. There are elements, when we can maybe talk about in discussion about overdiagnosis, that we may be treating other things that get lumped as ADHD because we just don't have enough school support that we just send children to take treatment. There's an element of truth to that. But it's also prevalent worldwide, as we said, and this rate is relatively stable. The medical agenda is being pushed by drug companies. We can't ignore that there are influences on prescribing patterns because of drug companies. But at the same time, even studies that are really good, non-pharma sponsored, like the MTA study that we're going to talk about, funded by National Institute of Mental Health, do support the existence of ADHD and the need for medications at the time to treat ADHD. Okay, so I think a lot of you are familiar with this. These are just some of the challenges you see at different age groups across the lifespan. So certainly academic limitations from the beginning, impaired family and peer relationships. If you're the child who's always being told to sit still and you're not listening at home and at school, it's likely to affect your self-esteem, particularly when you get into teenage years. These kids fall a lot, have a lot of injuries, physical injuries. They're more prone to smoking and substance abuse towards adolescence, young adulthood. They get into accidents more, they have legal problems and work and relationship problems. This is one of my favorite graphs, and I always cover this with the families because I think this is actually good news overall. So if you look at the three elements, the hyperactivity, the inattention, and the impulsivity, in general, there's an improvement as you get older. Now this is a differential improvement. Hyperactivity always gets better. So even adults who have ADHD, if you know adults who have ADHD, they're not usually as hyper as they were when they were 6. Now, impulsivity is interesting. You see generally a decrease, and then a spike, adolescence, and then starts going down again. Now for inattention, you see that that's the least symptom that improves with age, and that's why most adults who seek treatment for ADHD seek it for. Usually, it's because they can't focus at work. So these are the DSM symptoms of inattention. They're here. I'm not going to read them out for you, but you know, things that you're familiar with: being careless, making careless mistakes, difficulty sustaining attention, even in like one-to-one settings at times. Child doesn't listen, doesn't follow through, can't organize, and you need 6 out of these to meet the inattention criteria. And then the hyperactivity, impulsivity, again you need 6 out of 9 of these criteria. And it has to have been present for 6 months. One of the changes between the DSM-4 and DSM-5, DSM-4 required that there was evidence for symptoms before the age of 7, even if it was not diagnosed. So even if you had a teenager, but you asked and you know they told you when they were in 1st grade, when they were 6 years old, they still had this problem, even if they're not diagnosed, then met criteria. Now they relaxed it a little bit in DSM-5 to be 12 years. As some of the discussion my colleague alluded to earlier, Dennis talked about, is that there's a lot of comorbidities, and I think this is one of the biggest challenges we have in psychiatry in general, that although we would like to put things in categories, we know that they don't naturally exist just in these categories. So for example, conduct disorder is really high. You know, we say maybe 50% of kids with ADHD have conduct disorder. Substance abuse, learning disorders, anxiety in about 20 to 40%. Tourette's disorder, and you know we see a lot Tourette's with ADHD with OCD, this kind of triad. Mood disorders like depression, certainly bipolar. And also speaking of bipolar, this was one of the big kind of controversies when Dennis alluded to the increase in rate of bipolar. A lot of the people who were getting diagnosed as bipolar in the United States actually had more of an ADHD picture. It wasn't always clear, you know, is it just ADHD? Is there a mood component? This is one of the reasons why I think the diagnosis of bipolar went up pretty much. So in terms of decision making and treatment of ADHD, it's always like anything, risk versus benefits. You have to carefully evaluate the patient, the family, the presentation. You take into account the family history of cardiac disease specifically, and we'll talk about that a little bit later. Obviously, the past psychiatric history, past academic performance, stressors within the families, and certainly the use of questionnaires. It has advantages and disadvantages, but something we use pretty often in ADHD specifically. So the Vanderbilt in the US is available for free, so that's actually one of the most common used ones. That's one of the ones we use mostly. But there are others. Another piece of good news, ADHD probably is the best treated disorder in child mental health in general, in terms of medications. Oh, but that was not the slide I want to talk about. The initial psychopharmacological treatment in general should be a medicine approved by the FDA, the Federal Drug Administration in the United States. So what are the FDA approved medications for ADHD? First, there are the stimulants. They potentiate dopamine, norepinephrine neurotransmission. Atomoxetine, which I believe is available here, Strattera, which is a non-stimulant, and a norepinephrine reuptake inhibitor. And then there's several off-label medications, like the alpha agonists, guanfacine and clonidine, modafinil, Provigil, Wellbutrin, which we talked about earlier, and the tricyclic antidepressants, which we don't use, at least in the US, much anymore for ADHD, just because there's so many better options. So, you know, there's kind of several groups with several algorithms in terms of like which medicine should you start, because when I show you the list of medications that is coming a little bit later, there are really a lot of medications. There's about 12 medicines we could use. So which one do you start with? So generally we start with stimulants as a first line, particularly if there are no comorbidities. And usually if you try one of the stimulant classes, which is, say, usually start a methylphenidate, if it doesn't work, you move to the other class, an amphetamine. As I said, they're one of the best, ADHD is one of the best treated conditions with medications. So about 70% respond favorably to the initial trial, and maybe 90% to subsequent trials. And this is more significant with stimulants. If you're familiar with the concept of effect size, the effect size is actually really high for stimulants, 0.95 long-acting, 0.91 short-acting. With atomoxetine, it's pretty reasonable, but not as high as stimulants, so the effect size is 0.62. So are stimulants first line for everybody? The answer is obviously no. So tic disorders, for example, sometimes you go with Strattera directly, or you treat with a stimulant, but then treat with an alpha agonist or an atypical antipsychotic for the tics. Anxiety disorders, a lot of times you do start with Strattera because we know that stimulants can make anxiety worse. But sometimes you also treat with a stimulant and treat the anxiety separately. If there is a comorbid substance abuse history, we go to Strattera or a long-acting stimulant that has less potential for abuse. So this was one of the most seminal studies, and actually I think addresses a question you had earlier about kind of the role of medications maybe compared to other modalities in the treatment of ADHD. So this study was federally funded by National Institute of Mental Health, not pharma-sponsored. And it had almost 600 children at age group between 7 to 10 years old. And compared head-to-head 4 groups. Medical management with medications, intense behavioral management, combination medical and behavioral, both together, and routine community care, which basically meant people doing all types of combinations of things. So in 14 months, they found something very interesting, that the medication and behavior were better than all forms of treatment. So better than just behavioral alone or just regular community care. But the other interesting finding that they did not find much of a difference between medications only versus medication and behavioral therapy. Now, if you read the discussion of the study, the authors make sure to say that it does not mean there is no role for behavioral therapy. There is certainly a role for behavioral therapy in ADHD. But I think the take-home message from this study, which was very important, is that as opposed to most other child mental health conditions, probably behavioral therapy alone is not enough. And you may recommend medications from the beginning. While in most other disorders, like Dennis alluded to, like depression or anxiety, usually the first line is actually CBT or therapy, and then medications. If it doesn't work or it's very severe, or there's suicidal thoughts, you may start medications earlier. Now, what about preschoolers? What about the younger children? So this was another NIMH-funded study. It's called the PAT study. And it had preschoolers between 3 years and 5.5 years old. And it was a double-blind crossover titration of methylphenidate and placebo. They found in this age group that ADHD decreased in a dose-dependent fashion with the medicine. But the effect size was lower than school-aged children. In the United States, we don't treat a lot of preschoolers for ADHD in general. But when we do, we know clinically that sometimes the response is not as good as when they get a little bit older. And also rates of events or side effects is higher. And this study supports that. So this was the slide I mentioned earlier, that 70% of patients respond to the first stimulant, and response rate of more than 90% has been reported by switching non-responders to a second stimulant. All of us know everything else we treat, anxiety, depression, schizophrenia, autism, anything we use medication for, we don't usually see these numbers. Okay, so we know that there's a role for norepinephrine and dopamine in the pathogenesis of ADHD. Norepinephrine helps us disengage from stimuli, so kind of shift our attention, change focus, engage new stimuli. And dopamine helps in analyzing data and responding. So in terms of the mechanism of action of methylphenidate, it blocks the reuptake of dopamine via the dopamine transporter, which is known as DAT. Therapeutic doses block more than 50% of DAT. Also has an impact on norepinephrine and serotonin. So I understand from talking to colleagues that many of these medications are not available here. But I thought it's still worthwhile to, tell you a little bit about the different medicines we have in the United States. And, I think there's a question, maybe we do have too many medications. So first there's the short-acting, so just the methylphenidate, or what we just call as Ritalin. And then there's the dexmethylphenidate, which is known as Focalin. We know it's short-acting, so the duration of action is about 2 to 4 hours. So we usually dose it at least twice a day, if not 3 times a day. And then there are intermediate acting methylphenidate components. The first two here, we almost stopped using in the United States because they're wax matrix. So their release is a little bit unpredictable. So you give it to them and you don't know, do they get like a lot of effect in the first hour and like 5 hours? So we don't, they exist in the market. I don't know if anybody still uses them. And then there's the methylphenidate CD, known as Metadate CD, which we'll talk about because it has an interesting way of release. So 30% releases right away, and then 70% on a more extended release. Works for 4 to 8 hours. And then Ritalin LA, which works for 6 to 8 hours. And then we move on to the longer acting ones, which is the oros methylphenidate, which is Concerta. It works for 10 to 12 hours. And it has now gone generic in the United States, which is important because I think it's one of the most commonly used ones and the ones that a lot of us do prefer. And then there's the Focalin extended release. And then this one, it's a patch. It's a very interesting one. It's called Daytrana. It's a patch. You apply it for 9 hours. And then it works for the 9 hours in about 3 more hours. So this is the Concerta. And the patent on it, one of the things the patent was on is actually the mechanism of release, this like osmotically controlled release. So it's like 3 compartments, a push compartment, a drug compartment 1 and 2. So interestingly, when it's gone generic in the United States, we've noticed a lot of patients coming back and saying, actually the generic does not work as well. And it's probably related not to the chemical component, because it's the same, because they're not really able to get this, phasic release in a way that, the actual Concerta had. So this is the Metadate CD that I talked about earlier, and as we said, 30% of the dose is released immediately, rapidly released, and 70% is continuously released. And then 2 medications that have this SODAS way, spheroidal oral drug absorption system. Basically 50% immediate and 50% extended. So a little bit of a difference from Metadate, where we said at 30 and 70. And we can argue how much of a difference that is, but we know that for some kids, if you get a very careful history, you will notice that there are times of the day that are more difficult, and having these different formulations allows you to play a little bit with that. Do you want more to be immediately released, or less immediate release and long acting, or just using short acting? And this is the Daytrana patch I talked about. Amphetamines, this is their mechanism of action. They attach to presynaptic receptors, release dopamine, attach to synaptic vesicles, release dopamine, and then also increase norepinephrine serotonin. So these are the amphetamines that are approved for the treatment of ADHD. So basically in the short acting we have the Adderall and the Dexedrine. The short actings are still longer acting than the short acting methylphenidase. So 7 hours, with methylphenidate we said like 3 to 4 hours in general. And then we also have longer acting formulations here. So Adderall, the famous one, which again is a 50% immediate release, 50% extended release, and it works for 8 to 12 hours. And then the L-dextroamphetamine, which is Vyvanse, which also Dennis talked about earlier. We've had it in the United States now for quite some time, but it's still brand name. It's actually the only one that's still brand name in the United States. So it's more expensive. works for 12 to 14 hours. So it's one of the longest, together with Concerta and the Ditrana patch. So the Adderall also has this biphasic release, 50%, 50%. And this is the Vyvanse. Vyvanse is a prodrug. If you remember maybe from medical school, because I don't think we have a lot of prodrugs in psychiatry, this is a medicine that only becomes active inside the body. So that decreases the substance abuse potential of it. So, you know, it's not a medicine that people can just inject or, you know, get high on. Okay, I'll talk a little bit about interactions. I mean, in general, there's not a lot of interactions for stimulants. The real interaction, or actually contraindication, where you should not use it, if you use any monoamine oxidase inhibitors, antidepressants, we don't use it anymore in the United States. You know, some other countries they do, but we don't use it anymore in the United States. So there's really no true contraindication. But there are some interactions. So tricyclic antidepressants could be potentiated with the use of stimulants. Lithium could be inhibited. Anticonvulsants can have an increase in their anticonvulsant activity, so potentiated. And benzodiazepine is not, as far as I understand, a true interaction, but you know, you're giving something that is a sedative, something that is a stimulant, so you can understand, you know, a stimulant would counter effect the benzodiazepine sedative. So side effect monitoring is certainly very important. But I think what's really important, and what we should all keep in mind if we prescribe these medications, is that sleep and appetite are among the things that we say, you know, when I give parents, we talk about, you know, a stimulant, you know, I say in terms of side effects, some of the most common things you might see are effects in sleep and appetite. But the interesting thing is that many of these kids, with particularly sleep, have sleep difficulties independent of the medicine. So it's really important to know what the baseline is, because if you don't ask about their sleep and appetite, you may think it's just the medicine you're giving that's causing a side effect. And in reality, we know that, you know, children who have ADHD have more sleep difficulties. Okay, both methylphenidate and dexmethylphenidate, which is Focalin, can decrease appetite. Dexmethylphenidate more so have sleep difficulties and more so has mood symptoms. But the take-home point, check for side effects before you give the medicine, and certainly follow after you give the medicine. So the MTA study also looked at side effects, and they reported about 1 centimeter a year less height gained at 3-year follow-up, 2 centimeters or shorter, and 2.7 kilograms lighter. There is a small subset of children who tend to have more significant issues. But we also know that not every person or child who takes stimulant medication will have appetite suppression. Now, adult data shows that there's more subtle evidence, less effect on growth. Typically normalized to expected adult size, but there's variability in this, right? So basically what this is saying is that, yes, there could be an effect. Some people say that this effect, by the time you reach adulthood, just bounces off. Or, you know, you might be just a little bit shorter or a little bit lighter. So how do we manage appetite-related problems? High-calorie meals in the morning. So usually we say, have a heavy breakfast first, then take your medicine. Lunch is sometimes kind of a lost battle, because that's kind of the peak effect of the medicine. And then by dinner, most people have regained their appetite, so they can have a good dinner. We give drug holidays, so if we can, we say, that don't give it to them on the weekend or don't give it to them on holidays or in the summer. That helps them kind of gain weight. You have to keep track of it. You have to measure height and weight, and we measure it every visit. And then, the last approach, if everything is failing, actually before that, we give, sometimes like not energy drinks, but like, I don't know what they're called here, but Pediasure, just drinks that they give to children who are kind of malnutrition. And then the last approach, which is the least favorite, and we try to avoid, is to give a medicine to boost appetite, so like cyproheptadine. But it's really not a good approach though, because you're giving a medicine and then giving another medicine to deal with the side effect of the medicine you're giving, and next thing you know, you're giving a third medicine to deal with the side effect of the second medicine. So we really try to avoid this, but I've had a few cases where everything else we tried, including switching the medicine, moving, sometimes to non-stimulants, because Strattera actually affects appetite. Less so than stimulants, but it does affect appetite. I've certainly had people also, complain of that on Strattera. For the sleep impairment, prevention is important. As I said, screen before treatment. You can play with like shorter acting formulations if people's sleep is affected. And when I was saying, maybe we have too many medications in the United States, I think the advantage is that, it gives you a chance to fine-tune things. So maybe look for something that instead of 12 hours is 10 hours, or something that releases more or less at certain times of the day. So there are fine tweaks that having more medications helps you to do. And then there are certainly medications that can be used to help sleep. As Dennis mentioned, melatonin is usually our first choice. In the United States, it's over the counter. They don't need a prescription. You just go to the pharmacy and take it over the counter. But there are other things that you could use, like clonidine, trazodone, mirtazapine, and antihistamines like Benadryl. I wanted to talk about the cardiovascular monitoring because this has been a little bit controversial for stimulants. So in 2008, the American Heart Association recommended taking a patient history, family history, physical exam, and the baseline AKG for everybody starting a stimulant. And that created a huge fight, maybe. Because, imagine how many EKGs you would be getting for everybody who's trying a stimulant. So not much later, again in 2008, the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics issued their own guidelines, which was different than the American Heart Association. They asked to take a history, a physical exam, also a family history of cardiac disease, including sudden cardiac death, and a patient cardiac history. They have palpitations, syncope, hypertrophic cardiomyopathy. But only get an EKG if there is a report of sudden cardiac death or cardiac symptoms, and getting a cardiology consult if there are abnormalities in the EKG. And this is what I think most of us practice. We don't just get an EKG on everybody who's starting a stimulant, but we get it if there's a reason to believe there's more of a cardiac history. Another somewhat controversial issue, what do you do if there's a tic disorder? So first note that it's not a contraindication to give stimulants. And so in a meta-analysis, they found that methylphenidate did not worsen tics. Alpha agonists give relief to both tics and ADHD. So things like clonidine or guanfacine are used in the treatment of tics, and they can also help ADHD. If you remember, we said these are some of the non-stimulants used for ADHD. Atomoxetine and dizipramine, which is a tricyclic, are found useful in this case. they did find that in amphetamines, in really high doses, it can worsen tics. So, but in clinical practice, I certainly see people who, even on a methylphenidate, have worsening tics. So sometimes a little bit of a dilemma, you know. I mean, if you look at this is meta-analysis saying, well, methylphenidate generally doesn't, but in clinical practice we see that sometimes it does. But we also know that the tics in general wax and wane, come and go. So there also could be times where, you know, someone was presenting to you, they did not appear to have tics, you maybe didn't get a full history, and you started a stimulant, and now they have tics, which they may have had otherwise. So you know, I think this is where this issue is a little bit controversial. But I think the take-home message is that it's not a contraindication. You can still use stimulants even if there are tics. But certainly got to get a good history of, you know, the tics. And you can consider using non-stimulants like guanfacine or atomoxetine. Or combine a stimulant with a non-stimulant. Psychosis is another one. So the rate of developing psychosis, mostly usually hallucinations in this context, is about 1 in 400 if you start a stimulant. We believe that it happens in people who are biologically vulnerable, not necessarily, you know, anybody, like you give them a stimulant and now they develop schizophrenia. In a case series of 60 reports of psychosis with stimulants, 92% remitted after removal of stimulant. So, you know, you give a stimulant, the child is one of those 400, they develop psychosis. The good news is usually it's not a permanent psychosis, it's not schizophrenia. You stop the stimulant and the psychosis goes away. So I usually cover this with patients as part of the consent of starting a medicine. Ask about family history of psychotic disorders for sure. Now, if there's a family history, would you not do it, you know, again, controversial, but you may want to consider if there's a very strong family history of psychosis to start a non-stimulant. So another consideration is seizures, and I know Igor will be talking about seizures, so I'm not going to spend a lot of time here, but it's a very interesting relationship between seizures and ADHD. So the American Academy of Pediatrics estimates that about 39% of people who have epilepsy have ADHD, like meet criteria for ADHD. This is really high. This is almost 40%. While, you know, we know in the general population it's what, like 5%, 10%. So there's something there. But the other interesting thing is that for people who have ADHD, when you get an EEG, about 30% of them have an abnormal EEG, even in the absence of, you know, seizures. So there is an interesting bidirectional relationship. And together with some colleagues, we studied this a little bit. There are several theories about, you know, this relationship. I mean, certainly anti-epileptic medications, particularly some of them, like, you know, phenobarbital, are known to worsen symptoms that are like ADHD. It's focus, cognition. But this relationship still stands true even if you're not being treated for seizures. So, you know, is it the effect of chronic seizures? You know, a seizure is a disorder that affects the brain. Is there an effect of these like chronic seizures on your focus, on your cognition? Possibly, makes sense. There is a known adrenergic dysfunction that is shared by seizure disorders and ADHD. Common genetic defects or underlying neurodevelopmental vulnerability. So there is a belief among some that, you know, there could be a shared pathway that leads some people to have ADHD, some people to have epilepsy, or both. Okay, so back to kind of what do you do? Like if you have all these like 12 options or something for medications, like how do you choose? What do you do? Generally, there is not one medicine that's known to be better. So it's not like Concerta just works better. Everybody goes on Concerta. Or Vyvanse works better. Everybody goes on Vyvanse. So a lot of times, most algorithms say start a methylphenidate. If it doesn't work, move to an amphetamine product, and certainly assess for comorbidities or side effects, and based on that, consider non-stimulants. So, anxiety disorders, you may want to consider a non-stimulant. If the child is young or can't swallow pills, then you may have to consider the formulations that come as liquid. So Ritalin comes as a liquid. There are some capsules that you can open and sprinkle on food. And then there's also a patch. If there are premorbid sleep difficulties, you may want to give a methylphenidate product. Or if there's a mood disorder, a methylphenidate product and not an amphetamine. Like we do with antidepressants, we also ask about family history of response. So if there is, if the father was in Concerta and it worked, maybe you'll go to Concerta on the child. So you have to assess for side effects and for adherence. I always ask, what time specifically did they take the medicine? Because you'd be surprised. Someone might, if you say in the morning, someone might take it at 6, and someone might take it at 8, right before they leave the door. So this is already 2 hours. If you think of a short-acting formulation, then you've used half of the time before the child even goes on the bus to go to school. The other thing that's important, what time are the complaints from the teachers coming? So, is the child doing better on the medicine, but only the afternoons are worse? That's important information to know in terms of the timing of the medicine, or maybe adding a dose in the afternoon. And are they taking the medicine as prescribed or not? Okay. So you need to ask about when it wears off, the hours it works. You need to ask concrete questions, things like, I usually tell them, in a week, how many times were you getting phone calls from the teachers or complaints? And they would say 10. And then I ask, so after the medicine, what is that number? Grades, academic performance too. Harder with academic performance because it's not just the focus, it's the effort factor, right? If you're focused but don't do your homework, your grades are not going to be good. And we usually, work closely with teachers about getting scales. Recently in our hospital we developed an electronic tool. It's called Trivox, where through email it automatically sends notifications to the teachers and the parents, and they fill the scales online, and it graphs it for us. And the good thing about it, it's linked to our computer system, so it actually shows when they started the medicine. So we end up with a really nice graph that says, that date medicine was started, and then the symptoms went like this, or maybe not. So things to think about: if the medicine doesn't last long enough, maybe add a short acting, a booster dose. If it doesn't work soon enough, so sometimes you give Concerta and then it only works after an hour or a little bit more, then sometimes you even give a short acting medicine in the morning to just help kick off the process, particularly if they get into problems on the bus or something. I'm not going to spend a lot of time on non-pharmacological treatment because honestly this is a whole lecture in itself and I will not be doing it justice. But there's behavioral therapy, there's certainly working with the parents is important, working with the family is important, support groups and school interventions are really important. So there's not been major breakthroughs in medications after Vyvanse that came out in 2007. But there are newer medications on the market, but they're just maybe long-acting formulations of the shorter-acting medications. So there's a long-acting clonidine and a long-acting guanfacine. And the last one that just came on the market maybe a year ago is called Equivalent. It's just a long-acting liquid. So it's a good option for a young child maybe who can't swallow pills and actually needs something long-acting. So these are some of the colleagues I wanted to acknowledge: Georgina Garcia and Bruce Meltzer. If you're in Facebook, follow the YECAPAP page, the International Association. And this is my email. We might have time to take a few questions, but certainly feel free to email me too if I could be of any help.